My name is Esty Garrity, and I am the Chief Medical Officer at Esri. And I just want to thank you for joining us for this TechWity session, which is focused on enhancing equity with mapping, particularly when it counts the most. I mean, it's those really critical moments when somebody suffered a stroke, a STEMI, a cardiac arrest, or potentially traumatic injury. I'm very pleased to be joined today by my colleague, Dr. Ben Weston, who is an expert when it comes to these high-stakes moments. Dr. Weston is a practicing ER doc, and he is Associate Professor of Emergency Medicine with the Medical College of Wisconsin, and he also crosses over into the public sector as the Chief Health Policy Advisor for Milwaukee County. And he is also the Director of Medical Services for Milwaukee County's Office of Emergency Management. We brought the right person. So, by way of introduction to this topic, and maybe I could even say to kind of get us into the right headspace for the conversation, I actually have a confession to make. I'm a topophiliac. It turns out this is widespread, and it is contagious. Dr. Weston has it, and I'm guessing many of you may have it as well. And of course, topophilia simply refers to a person with a strong sense of place. In fact, for me, place is so compelling that it absorbs not only my entire career, but actually my lifestyle as a digital nomad nowadays. So what you're seeing on screen are the tracks of my travels, some of my travels, mostly walking, over the past 8 months. So I am absolutely fascinated by how we move through places, what those places mean to our health, and especially what they mean to equity. Now, for today's conversation, we're really going to focus on two components of mapping that will support more equitable emergency response. So the first of those critical components is understanding access to care. Okay, so traditional calculations of access were really focused on using Euclidean or straight line distance measurements to really get at a patient's access to their healthcare provider. And for simplicity's sake, often what would happen is that we would use the patient's zip code centroid in order to do that calculation. But of course, there's a problem with that. Not everybody lives right in the center of their zip code. So what happens is you have this potential to start to mask access disparities. But there's another problem. How many of us actually travel in a straight line to our provider, right? So what we really need is geographic context in order to truly understand access to care. And we can do better still. Right? We can start to add data on speed limits and common traffic patterns so that we can supplement that distance measurement with hyper-accurate travel times. And travel time is especially important. But we can also look at access from a different perspective. Maybe you'd call it a population perspective or from an institutional point of view. So here what you're seeing is a hospital with 15, 30, and 45-minute drive times. And actually, this brings me to my second critical component of mapping and how it supports equity. And that is using population risk or population vulnerability data. So you see, when you have that, what you can do is you can take, for example, that 45-minute drive time and you can enrich it with more data to better understand neighborhood level issues of equity. So the feature that you're seeing here is people with the lowest levels of English language proficiency. But guess what? It could be any measure that you think is interesting or relevant to the questions that you need to answer. Or you could use multiple measures and put them together like as an index, or use an existing index, maybe something sort of like the CDC's Social Vulnerability Index. Now, Ben, I think that you used that index for the work that you did in Milwaukee County in improving equitable vaccine distribution. Can you talk a little bit about that work?
That's right. Good morning. So what you're seeing behind me here is the EVE model. So this is a model that we created in Milwaukee County. It stands for Evaluating Vulnerability and Equity. Now, the first use case for this model was COVID vaccinations. And so what it is, it's fairly straightforward. I'm blocking most of it here, but it's fairly straightforward. You can see along the bottom, the x-axis, social vulnerability index from the CDC, and then along the y-axis, vaccination rate. And so what we tried to do is target the orange communities. So these are communities that are highly vulnerable, but had not received much vaccine. And so when you lay it out in census tracts, you get this color-coded map that you see to the right. And so that's the map that we used throughout and continue to use for COVID vaccinations. And for those orange communities, that's where we open our vaccination sites. That's where we do our focused communication, our interventions, and give the most resources to those communities to really change the vaccination landscape in that region. And we purposefully kept that V from being vaccine because we knew we could apply this to other areas. So we've applied it to gun violence. We've applied it to opioid overdoses. And similarly, we can do focused communication, focused resources, and targeted interventions.
I love how simple and clear the EVE model is. And I know you've told me, and you started to mention it here, that you really used it for decisions about vaccine distribution, about community messaging, about the importance of vaccines. Can you tell us some results? What value did you get? How did it work?
Sure. Now, there's a lot of moving pieces to targeting vulnerability and equity in vaccination, but this was an important one for us. So before this model was released in January of 21, when the vaccine first came out, about 5% of our doses of the vaccine, first doses, were going to the lowest quarter of vulnerable populations. So our most vulnerable populations were only getting 5% of the vaccine. We put this in place. We worked with the state to allow us to open up vaccines to these orange communities. And again, we communicated, we targeted, we knocked on doors. We opened small-scale sites in barbershops, in churches, in community organizations. And a short time later, and this remains now, about 50% of our first doses go to that most vulnerable segment of our population.
I think that's awesome. And actually, I'm going to intentionally make the screen blank in case you wonder. The slide's not malfunctioning, just so that we can continue the conversation. And I know that work around the EVE model was very inspirational for you and for your colleagues in Milwaukee. And so then, given your multiple hats in emergency medical needs, you started to think about how you could apply that there. And so you're focusing now a lot of your efforts on those 911 emergencies that are time sensitive. I mentioned them in the beginning. Those are the strokes, the STEMIs, the cardiac arrest, and the trauma. So I'd like to hear more about the work that you're doing there. I mean, isn't this just, using it for ambulance response times, or do you really care about those calculations of access and population vulnerability in that work?
Yeah, we definitely care about it. So one of my other roles in Milwaukee County is as the EMS medical director. So in Milwaukee County, we're a fire-based EMS system, so our fire departments are responding to our 911 calls. And we're one of the larger systems in the country, of about 115,000 patient encounters a year, so almost a health system of our own. Now, when you think about these sort of time-sensitive calls, how the ambulance responds, you really need to break them into pieces. So when you call 911, you wait a little bit till you get a dispatcher. So that's time period 1. And then from when you get that dispatcher to when an ambulance is actually sent, that's time period 2. And then how long that ambulance takes to get to you, how long they're on scene, how long are they assessing and doing medications, and times when time matters, like a stroke. And then, of course, transport to the hospital time. Now, there's a whole lot on that hospital end that you can evaluate as well, and we do. But from the pre-hospital environment, you can really break it down into those individual timepieces to better understand not just how effective the care is, but the disparities in care as well.
So when I was showing before that it's useful to have hyper-accurate time measurements, you can apply that directly to this work.
That's exactly right.
And so tell us about the component of how do you measure those different times against community risk and vulnerability?
Yeah, so one of the unique things about Milwaukee County is in 2019, so the spring of 2019, before COVID, we were the first in the country to declare racism a public health crisis. Now, what that did for Milwaukee County was it made every one of our departments, whether it's Parks, Department of Transportation, or certainly the Office of Emergency Management, make every one of our decisions through an equity lens. And the same applies for our EMS system. So when we think of disparities in EMS care, we know there's a lot. We know that African American folks are less likely to receive pain control in the pre-hospital environment. Hispanic folks are less likely to have their strokes recognized. Women are less likely to receive cardiac arrest interventions. The list goes on. But what we're trying to do is look at that from a time-based component. And each of those different times have different reasons. So your dispatch center in a low-income community might not have as many dispatchers. So you may wait longer to have that 911 call picked up. You may not have as many fire stations, or they may not be as closely located to the poorest communities. So it may take longer for that ambulance to reach you. Now, the scene time is a little bit different because that's all in the hands of the paramedic and how well they're trained. So that really is my fault if they're taking too long. But then hospitals are located in different areas of the community, and especially when you get to those specialty hospitals for strokes, for cardiac arrest, for trauma, each of these conditions, only certain hospitals are able to care for them. And so you need to look at how those hospitals are distributed in your community as well.
Now, I think that you use these concepts to really mock up an informational dashboard so that you would have it right there to give you the real-time information to be able to make decisions. Can you walk us through what that's like?
That's right. So this is an example of what that dashboard may look like. Now, this is demo data. And again, I think I'm going to block some of it, so I'll move. But you can see off to the left those different times. I'll grab this. So you can see the average dispatch time, average response time, scene time, transport time laid out. And if we click on one of them, we drop it down here. We click on stroke, for example. We can see those times. We can see some disparities over here and trends in those times. But maybe most critically, we can see the mapping of those times and understand what communities are experiencing longer response times to get to the patient. And we can cycle through. Instead, we can go to scene time. And we see a different sort of map of where in the community is it taking longer to assess that stroke or to treat that trauma and package that patient up to get them to the hospital. And then we can also start combining and say, all right, let's look at response and scene time together and see a more holistic picture. But it allows us to target those communities in different ways. It might be implementing new quality improvement metrics for those dispatch centers, or it may be thinking about building a new fire station in an area where there isn't one, or doing more dynamic dispatching of where ambulances are stationed, how they get to patients that are most in need in different communities.
So I want to get even more specific. Maybe you can walk through a specific scenario, thinking about what you anticipate is going to be a disparate outcome in pre-hospital care, and how you're going to use this, and a decision you think you'll be able to make once you have it all mapped and ready.
Absolutely. So let's stick with the stroke example, okay? So when somebody is having signs and symptoms of a stroke, they call 911. Now, the first thing that needs to happen is that ambulance needs to get there, because every moment that that person is sitting with their stroke, brain cells are dying, they're not coming back. And so that is a true emergency. A lot of folks think every 911 call is a true emergency. Sorry to say they're not, but there are certain ones that are, and they're time-sensitive emergencies, and that's what we look at on a dashboard like this, and stroke is one of those. So the first thing we need to do is that dispatcher needs to rapidly recognize this sounds like a stroke, because the patient may not. They may be calling because somebody's dizzy or they're having trouble talking and they're not sure what's going on. So that dispatcher needs to be trained and have the right technology to assist them to recognize that and send that unit. Then that ambulance needs to get there rapidly. And there's technology that goes into that as well. They have technology on board to make the lights turn from red to green. They have technology to tell them which route is going to be fastest, how to get to the right location, and where the patient actually is. Is the patient if they don't know where they are and they're not able to speak, are they on the ground floor, or are they on the 10th floor? And there's technology at play for all of that. And then once they get there, of course, they need to be trained to recognize that stroke. And then everything goes in reverse. Now the ambulance has to leave and bring them to a hospital and prepare that hospital. And so there's different technology that goes into that, of alerting the hospital. A lot of times there's ways for the hospital to see the actual patient care record. They may see the monitor to understand how stable that patient is, and then get everything prepared so that the moment that patient arrives, they can hit the ground running to treat that stroke.
It's a lot going on. I'm glad I'm an internist. Just an aside, folks. So So maybe you can also expand on this. So you got me thinking, and I hadn't really. So this is a surprise question. Um, I hadn't thought very much about this until just this moment. So you said you wanted to use the EVE model for assessing gun violence, and now we're talking about pre-hospital care. We included trauma in some of those time-sensitive emergencies. Will there be double the benefit in looking at it through this new geographic perspective, or is it just incidental?
No, I think there will. So the dashboard you see behind me right now doesn't necessarily take that vulnerability into account. Now, it shows you a racial ethnic breakdown, it shows you a sex breakdown, and it shows you a geographic breakdown. But the next step we hope to take is to develop an EVE model based on that. And so, for example, you might take response time here and look at it broken down by vulnerability and understand, why is there a longer response time in certain communities? Maybe it's just the built environment and it has nothing to do with vulnerability, but chances are we're going to see that it does have to do with vulnerability. And as you go up on that social vulnerability index, you're also going to go up on your response times. And so just like we did with COVID, we have the different colors, and we can look and we can target those orange communities. And instead of having an entire county of over 1 million people to try to think about and target every single one equally, we can do it more equitably. And we can look at the communities that are most in need, and also typically with the most vulnerable communities, they're also the lowest resource communities. And so by pushing resources toward those communities, working with the elected folks there, the fire chiefs there, the hospital administrators there, we can better affect change in those communities.
Well, I want to tell you all that Dr. Weston is a very brave man, not just because he's an ER doc, but because he's planning, I believe, to share a version of this dashboard publicly. And I think for a lot of institutions, providing that kind of information is very scary. There's a lot of accountability issues, and I think maybe some benefits as well. So what do you think are the benefits and the challenges to doing that?
Yeah, so one of the first dashboards that we really focused on was our COVID dashboard. And we worked a lot with Esri on that and putting together a comprehensive COVID dashboard. And we made all of that transparent. And the reason we did it then was for a number of reasons. We knew we could make an internal dashboard and we'd be able to see it, and the public health officer would be able to see it, and some of our government colleagues would be able to see it, but that didn't seem like enough. We wanted also, of course, to inform the public. People wanted to know what was going on, but I think the most important group is those unknown unknowns. And I often think there's a quote from Donald Rumsfeld. We could talk all day about the pros and cons of Donald Rumsfeld, but he did have a good quote. And he said that there's known knowns, there's known unknowns, but there's unknown unknowns. And that's been the most interesting group, the folks who look at our dashboard. We also have an EMS dashboard where we look at different conditions and how we're doing. And the folks who look at that dashboard who we never anticipated, the community organizations that are using it to improve and target their work, or the academics that are looking at it and using it for research to disseminate nationally so others can do similar things. We never thought of those people. I often think about 6 months into the pandemic, we met with a woman who was a researcher at a local university, and she said every Wednesday night she'd sit and she'd look at our COVID dashboard, and as you hover over the census tracts, it gives a pop-up of what the vaccination rate is. And she said her and her husband would each have a glass of wine, and they'd sit there Wednesday nights, because that's when our data came out. We're hovering, and she'd read it off, and he'd type into Excel document, and he'd read it off. And when we met with her, we felt back, so we said, we'll just send you an Excel document every Wednesday if you want. But it's people like that who, by making your data transparent, they can use it and they can implement it. And so keeping it to ourselves, I think, really would limit our ability of what we could do with it.
I think you just put into practice what was being discussed in the plenary this morning. Did you guys hear from United Health Group CEO Sandeep, who was talking about how do we take Moore's Law and continue to go 100x? How do we expand our efforts? And I think I never thought of it this way either. You're just enlightening me today about when you expose the unknown unknowns. That's really an opportunity to go 100x. You found out something you can really take off with.
Yeah, and I think, there is resistance at times. So for example, our current EMS dashboards also look at hospital data. And so it shows to some extent how hospitals are performing, what hospitals patients are going to. But we've had, it's different in every community. We've had very good buy-in from our hospital partners, I think in part because we proved it with the COVID dashboard how important this work was. And we also pull in all those stakeholders ahead of time. We're meeting with all the hospital leadership, the fire department leadership, the government leadership, the electeds to show them this well in advance so they can we can get buy-in and they can give input of how they'd like something to look. They're curious about certain metrics, and so we can add those to the dashboard as well and kind of satisfy all the different folks involved.
So, so this is a self-serving question, but couldn't you do all of this without maps?
You could do a lot of this without maps, but I think you'd lose a couple critical components. So one component I think is obvious, which is data. I mean, obviously, the map tells a certain story. The other thing that I've found to be really valuable with maps is I think it makes the dashboard and the data much more approachable, especially from a public lens. One of the things we've tried to do with each of our dashboards is understand that we're going to have all sorts of different people looking at it. There's going to be PhD epidemiologists who are going to look at our dashboards and want to use all the different layers of the maps and the data downloads and analytics tools. But there's also going to be folks who've never really played around with a graph before. And we try to use simple graphics. You can see it here. It's the kind of stuff you see on like the 5 o'clock news. It flashes up for 10 seconds and it's gone. But you can understand there's a trend that's going up. There's a trend that's going down. You can get a lot more technical if you, this one doesn't have it, this mock-up, but there's all different sort of tabs and you can get into detail. But I think what the map does in particular is it makes people more comfortable. Most people, if any of you lived in Milwaukee County, you'd look at this map and right away you'd know, oh, that's where I live. Why is it dark red? Why is it white? Why is it in between? And your eyes, I think, are drawn to that and it becomes familiar and comfortable because most of us have seen a map for where we live. And you may not have seen different graphs. You may not understand, why something's up and something's down or is trending this way or that. But the maps with pretty understandable colors as you get, bolder colors that things are worse or better or whatever it is. And it draws your eye and it makes you feel more comfortable. And at that point, then you might dig around and play with some of the other things on the dashboard as well.
So this is clearly a safe place for topophiliacs. And, I think I want to start to bring our session to a close. And I think you've made it pretty clear that there are two components of mapping that can be particularly supportive of those pre-hospital critical conditions and improving equitable response to those conditions. And that is understanding access to care from as accurate a perspective as you can and overlaying population risk or vulnerability data. Just those two components, and you can innovate like my colleague Ben Weston from Milwaukee County is doing. And so I really want to thank you for coming all this way to Nashville and sharing your innovations with this group. And I want to thank all of you for joining in this TechWitty session. We are here to have conversations about this and any other place-based thing you'd like to talk about, actually anything you want to talk about. But this is our contact information if you'd like to talk now or a little bit later. We'd love to have those conversations. So thank you for joining us.
Thank you.